Hi, my name is Lori, and thanks for joining us here today at UT Southwestern Medical Center. It's the 1st of November, so we are kicking off Pancreatic Cancer Awareness Month. And here today to chat with us is Dr. John Mansour. So welcome. Thank you for joining us.
Thanks for having me.
Glad to have you here. Dr. Mansour is Chief of the Division of Surgical Oncology, and he's also head of the GI Cancer Disease-Oriented Team. So we're very lucky to have him here, and I know you'll have a lot of questions for him today. Don't forget to like and share the conversation with your friends today. Ask questions in the comments section of the Facebook feed throughout the chat, and we'll take as many questions as we can get to. If you have any issues, just try refreshing your browser during the chat. That usually helps. I also would just like to take a moment to thank our partners at Moncrief Cancer Institute in Fort Worth and PanCan for supporting this Facebook Live. Thank you very much. Okay, well, let's get started talking about pancreatic cancer. And how about we start with the big picture, Dr. Mansour? How many people are affected by this cancer?
Yeah, it's a good place to start because pancreas cancer is becoming more and more common in the United States. Right now, it's somewhere around 40,000 people every year are diagnosed with pancreas cancer, and obviously that impacts their families and their larger picture. But that number just is climbing. It's increasing at a rate that is a little faster than many other cancers. So it's something that's important to keep an eye on. Probably part of the reason why it's increasing so much is because obesity is increasing and the age of our population is increasing. And I think those are two factors that we associate.
Okay, so that's interesting. So being obese and being a little bit older would be a risk factor for this.
Correct.
For this cancer. Okay. We are getting questions in already. I just wanted to ask you first about the survival rate because I understand that for this particular cancer, it's actually quite low. You want to tell us about that?
Yeah, so it is low, and it's really a challenge. Overall, 5-year survival rates are less than 5%. And even in patients who have surgery where the cancer can be removed at 5 years, only about 25 or 30% of patients are still living.
Wow.
And the real challenge, I think one of the real challenges is that about 80% of people, by the time it's diagnosed, the cancer has already spread. And that's really where I think, are focusing a lot of our efforts, and really where a lot of our questions and a lot of our innovations need to be angled as to how we can do better in that regard.
So what we want to do is catch it early before it spreads.
Correct.
And where is that, in case somebody doesn't know, where is the pancreas exactly?
It's sort of in the middle of our abdomen, kind of right underneath our rib cage, way in the back.
Okay.
And it does lots of things. It helps us with insulin production and monitoring our glucose, keeping our glucose levels good.
Okay.
But it also helps us digest our food, which is an important part of
a
big part of what it does. Yeah, it's a big part of what it does.
Very important and kind of tucked in and hidden.
Correct.
Okay. All right. Well, let's see what kind of questions we have coming in. Here's a question from Georgia who wants to know, is there a link between pancreatic cancer and other types of cancer?
Well, it depends. So it is an interesting question. So there are several genetic syndromes, which we may talk about a little bit more, where different cancers are linked to each other.
Okay.
But I think we could talk about those at length. So I guess the answer is yes, but broadly the answer is no. It's most people who get pancreas cancer don't have some other type of cancer.
Okay. All right. Good to know. And here's a question from Tracy. Why do we find pancreatic cancer so late, and is there a way to have an annual test for this?
Yeah, so those are two really good questions, and probably some of the questions I get more than any other.
Okay.
Why do we diagnose this so late? It has to do with the nature of pancreas cancer. Pancreas cancer, cancers that start in the pancreas, there's something about them, something genetically, something about their biologic behavior that makes them prone to spreading quickly.
Okay. When
they're very small, even, they spread quickly. And in most cancers, that's not true. They have to grow a little, they have to establish roots. But something about pancreas cancer, it spreads quickly and at a very early part in its development.
Okay.
And we don't totally understand why that's true. But that's clearly the most important factor. And the way we're going to ultimately change the survival outcomes for patients is understanding why that happens. Understanding what is it, what's the feature about pancreas cancer that makes it want to spread so quickly, so early, and makes it able to spread so quickly
Sure.
and so early. In terms of screening, there are tests where we can identify small changes in the pancreas, things like MRIs and endoscopic ultrasounds,
Okay,
CAT
good.
scans to some degree.
Uh-huh.
One of the major focuses of our efforts is to try to identify who are the patients who are best served by undergoing a surveillance strategy like that. And that's one of the things that we spend a lot of time thinking about.
So trying to decide who should be screened.
Who should be screened.
As well as how.
Correct. Because
Okay.
with many other cancers, something like breast cancer, for instance, all women in a certain age group, they get screened. We don't even have a risk group that well defined for pancreas cancer. Colon cancer, we have a similar strategy. We know who should get screened with colonoscopy. But pancreas cancer, we don't really know who should get screened.
That makes it very tough. Thank you for that question. We also have another question about, is there anything promising on the horizon? For example, Virginia is asking about an endoscopic ultrasound of the pancreas through the stomach wall. She says, I realize early detection is so vital, yet no, it hasn't been very likely in the past.
Yeah. Thanks for that question,
Yeah.
Virginia. You're really hitting a key point here, and I mean, I can expound just a little bit, Lori, on what was I saying before?
Sure.
We have two ways to screen, to find it, quote unquote, find it early. Endoscopic ultrasound, which is a test where a scope is put into the stomach. The stomach lays right on top of the pancreas, so you get a really nice look at it that way.
All right.
And that's a really good test. It's really important for a lot of patients to evaluate what we see in their pancreas. It's very important for that test that you have somebody who does a lot of endoscopic ultrasound, who's an expert in this and an expert in looking for things in the pancreas. But it's not a perfect test. There's certain parts of the pancreas that are harder to see, and it's very operator dependent. In other words, it depends on how much of an expert your expert is.
Oh, yeah, it takes quite a bit of skill.
Correct, and experience. And then the other test that we use a lot is MRI. And so MRI is a very safe test, especially for people who don't have a lot of metal in their body, a pacemaker or something. It can sometimes be a problem. But MRI is a very, if it's geared to finding something in the pancreas, if that's the purpose of the test, it can be very sensitive at finding abnormalities in the pancreas. We don't really know how sensitive it can be. We don't have those numbers. We're constantly perfecting the strategy of how to turn the dials on our MRI to make it the most sensitive it can be. But those are really the two tests I think we focus on the most, MRI and EUS, endoscopic ultrasound.
Okay, thank you. Here's a question from Paige, and she wants to know, what are some signs and symptoms people can look for to catch it early on?
Yeah. There aren't a lot of signs and symptoms, and to our previous questioner's line of thought on this, there's not there's not a lump you feel, there's not a change. We can see changes when the tumor has progressed a little bit. People can become jaundiced, their eyes can become yellow. I think we've probably seen somebody like that.
I've heard about that.
Yeah. But it's really pretty subtle. Finding something early, an early pancreas cancer, really pretty rarely has signs and symptoms. The one thing I would say is that if you, so one of the things we're learning more and more is late onset diabetes. So someone who's never really had diabetes has always been pretty healthy.
Diabetes is definitely
not diabetes in and of itself, but if you never had it and you're an adult and you've never had diabetes and you've always been about the same health, haven't gained weight a lot, living your life normally, and all of a sudden you develop diabetes. Not for everybody, but that does seem to be a warning sign for some people, and we're learning more and more that may be a clue for us.
That's interesting.
Yeah. Some of the more late stage things are things like jaundice and weight loss and abdominal pain. But I think if we want to aim to identify early cancers, we need to find some tests that find the disease before it presents with symptoms. That's really the key.
Really challenging.
That's really the key.
All right, so here's a question from Ruth who wants to know, is there any genetic predisposition to pancreatic cancer? Ruth says that her grandmother had pancreatic cancer.
Yeah. So this is a great question, and Ruth's question is really important because we know about some of these syndromes like BRCA1, BRCA2. Sure. Other genes are less well known, things like ATM, PALB2, all these things. But one of the most strong predictors of developing pancreas cancer in yourself is a family history of pancreas cancer.
Really?
So that's really key. So knowing that, and for somebody who's watching this and thinking, boy, this is important to me because it's part of my family history.
Sure.
It's really important to pursue that. And by pursue that, I mean, I think, setting up an appointment with a genetics counselor who can help assess what your risk is. Obviously, that risk for any individual person is greater the more family members and the closer to them that they are. So mother, father, brother, sister is a stronger influence on your risk for pancreas cancer than if it's, a more distant relative.
Okay.
So I think that is one of those things that really is not well understood. We talk in all these fancy terms about genes like BRCA1 and 2, but just simply knowing our family history is probably more important than all of those things.
That's really interesting. So that's good to know for those of you who might have a family member affected, that it sounds like it would be worth scheduling a counseling appointment.
No question.
Okay, thank you. We have a question from Sierra who wants to know, what is the difference between exocrine and neuroendocrine pancreatic cancer?
Yes. So both very serious types of tumors, no question about it. When we generally talk about pancreas, they're both cancer, but when we generally talk about pancreas cancer and these very challenging survival outcomes, we're talking about pancreas adenocarcinoma, which is exocrine pancreas, which is
that would be the first type.
Is the first type. That's really what we mean by pancreas cancer, and we're referring to that. The endocrine tumors in the pancreas are different, and they're a little less common. They're less aggressive in the sense that patients do better. They live longer and have a higher cure rate when they have pancreas endocrine tumors. They sometimes can be associated, when we think about symptoms, with a pretty unusual constellation of symptoms, because these tumors can secrete hormones that, such as like insulin, can give people extremely high insulin levels.
It's messing with you.
Yeah, it's messing with you. And so I think it's really important to understand the difference. The treatments are very different.
Okay.
The behavior of the tumors in terms of their aggressiveness is very different. Thankfully, they look different on a scan, so we frequently can tell the difference. And it's not, it's not infrequent that somebody comes to us with the idea that they have the more aggressive version of a pancreas tumor, pancreas adenocarcinoma, and we can look at the scan and say, it doesn't really have those features. This looks more like a pancreas endocrine tumor, and there are many more options for treatment available, and the prognosis is much, much better. So that's a really key distinction to make for a person in our family that's trying to struggle with a pancreas tumor.
Thank you. That's really good to know. I thought there was all one size fits all, but definitely not. There's
very
different types.
Very different.
Okay,
yes.
Good to know. I wanted to take a minute to remind everyone to please continue to post your questions. We have some more coming in, and take a minute to like the post and share it with your friends. We're about halfway through, so we can still take more questions from Dr. Mansour. And I wanted to also cover risk factors, because some questions that were coming to me in advance of the chat, people were asking about things like diet or exercise or smoking, for example.
Right.
Do any of those things play a role in your risk?
Right. People ask me all the time what they can do to reduce their risk of getting cancer. And, the good news and maybe the bad news is it's the hard things. It's hard modifications that really will change our risk of cancer. And it's things like not smoking cigarettes, reducing that risk. That's a tough thing for people to do, and I really understand that. And obesity. Obesity and being overweight, carrying extra weight, many cancers, and pancreas cancer is one of them, seem to be more associated with obesity as well. And so those are really tough behaviors to change, and lifestyle things to change that we all struggle with. But that's really where the risk modification, the risk reduction happens. That's how we can really improve our chances. And there obviously are so many other reasons to try to model those healthy behaviors. And so it's just another really great reason to tackle a difficult problem like smoking cessation or obesity.
Right, so, that's a great reason. And particularly perhaps for those with a family history of pancreatic cancer, they can consider lowering their risk in those ways.
Correct.
Yeah.
You know, the one thing I will say, and along those lines, is I think people sometimes ask me about more extreme kinds of behaviors that can the dietary changes. If I eat more of this or eat less of that, I really caution people about those kinds of changes.
Why is that?
Because there's no evidence for any of that, and people really change their lives and become less healthy because they take on these extreme changes, lose drastic amounts of weight, or eat very extreme foods that don't give them a balanced diet. And there's no evidence that it reduces the risk of pancreas cancer, and it may cause problems in other ways, or in other parts of your life. So I just would be really careful about those kinds of things, and there are a lot of those ideas out there.
Okay, so that's some really good
But I think people who are listening to kind of this sort of a chat, or people who are looking for really good, solid information, and that. So I think probably people listening to this are maybe more in line of looking for mainstream traditional medication, or lifestyle changes. And that's really where we probably should be right now.
Okay, great. So we have a question from Marilyn who wants to know, can you discuss some of the newer treatments such as stem cell treatment?
Right. So for those of you who don't know what Marilyn's talking about, stem cells, and particularly cancer stem cells, are the cells that are sort of at the root. They're the first cell, if you want to think of it, that is where the cancer originates, and we think it's more resistant to chemotherapy. We think it's more resistant to potentially radiation, and it's a relatively new concept that there's a stem cell, there's an originator cell. We don't treat. There's no proven effective therapy of treating patients with stem cell transplants, or things that we do for other cancers. We don't have anything like that. If we want to talk about newer therapies, I think that it's very interesting because, and one of the things I like to talk to patients about, and one of the reasons why there is more hope now than there's ever been for patients with pancreas cancer, is that even in the last few years, after decades of not having much to offer in terms of new chemotherapy, we now are starting to see some really improvement in patient outcomes and prolonged survival, increased cure rates with a couple of new chemotherapy regimens.
So that's really good news.
Right, and so one of those regimens is FOLFIRINOX. One of those is which is a combination of drugs. The other one is another combination called gemcitabine and Abraxane. And those combinations, we did not know that they worked even 3, 4, 5 years ago. And so it's very exciting because we feel we have this to offer to people, and we're seeing tumors shrinking in a way that we didn't necessarily see before.
That's great to hear, and I imagine that is probably combined. Tell us about other types of therapy. For example, you mentioned surgery.
Correct.
And radiation, is that used at all?
So surgery is we use this term that surgery is the mainstay of treatment for pancreas cancer. And what that means is that, in the simplest terms, if a patient can have their cancer removed, which is a complex operation that I'm happy to talk about.
Sure.
If they can have it removed, then they do have a chance of 5 years down the line not having any cancer come back. It's around 25 to 30%. If the tumor can't be removed, unfortunately those chances are really low. And so without surgery, without being able to take it out, we really are thinking about treatments that aren't going to necessarily make the cancer go away. So surgery is the mainstay. It's a very big operation. I strongly encourage people to find an expert that does it. This is not
Right.
something that should be done by someone who does it once or twice a year. It depends a little bit where in the pancreas the tumor is, as to how complicated it is, and that's a complex discussion. But I think the key really is, you want to make sure that you're getting treatment someplace where this is a common problem for people to tackle.
I understand. So like here at UT Southwestern.
Correct. Here at UT Southwestern we do a lot, but
right.
but there are other places that do as well. And so I think that's just the key, is to find somebody who does this all the time.
Okay.
That's really, really important.
Good advice.
You asked about, I think Marilyn asked about other new therapies. The other thing that probably is on the top of a lot of people's minds, and I think there's some questions about it, is about immunotherapy.
Yes.
We can't open a magazine without
reading
about immunotherapy.
It's been everywhere.
And it is really exciting. And for those of you who don't know, or if you don't know, immunotherapy is an idea that's been around for a long time, which is to try to turn on our own body's immune system and get it to fight the cancer for us. Our immune systems fight cancer as it is, and they fight infection and other things. But how do we get it to work? And the real innovation that's come up recently, and particularly in other types of cancer, is not how to turn on the immune system, but how to release the brakes from the immune system. So just let it go as it normally would.
Okay, yeah.
And there have been some really incredible strides in diseases like melanoma and non-small cell lung cancer. We're exploring those treatments in pancreas cancer. Initial experience has not been as promising as in some of those other treatments or other diseases. But I think that there is a lot of room to be hopeful about the role of immunotherapy, and I think we just have to answer that.
That's good to hear. It sounds really promising.
Yeah, I hope so. I really do hope so. So, but every disease is a little different.
Sure. Okay, thank you. So we have a question from Diane, which is really interesting. She said, is anything being looked at that might make the body less of a welcome host for pancreatic cancer? I like that expression.
Yeah, I like that too.
And she says, for example, acidity versus alkalinity.
Yeah. So that's that involves sort of changing your body chemistry. That's the idea, to change your body chemistry. It's actually extremely difficult to acidity and alkalinity is measured in pH. We can't really change our body's pH, no matter how we try. We can change the pH of our urine, or we can't really change the pH of our body.
Okay.
It doesn't really. We have so many systems that are
complex,
built to keep it in a certain safe zone that we can't really change it very well. A lot of people have explored this idea of sort of the extremes of acidity and alkalinity, and the honest truth is there's some basic science evidence that doesn't really pan out in human experience when we look at it in actual patients.
Okay.
So I think I generally caution people against those kinds of adjustments in their life to make their body more acid or more alkaline. Number one, because I think it doesn't necessarily achieve that standard for them, and really it doesn't. There's no evidence that it actually helps people. You'd be much better off making your body less hospitable by doing things like we talked about, living a healthy life, stopping smoking, being less obese. So those are the things that I really would encourage people to focus on.
All right, thank you. We have another question about the nano knife, and this is from Catalin, or possibly Catalin, I hope I'm pronouncing that correctly, and she'd like to know, can the nano knife procedure be a possible treatment for non-operable pancreatic cancer?
Right, so treatments like very focused radiation or irreversible electroporation, which are treatments where we try to sort of focus on the tumor and treat it in a way where we can't separate it from blood vessels or something, and it can't be removed. There is some exploration into this and some innovations, clinical trials that look at this. I think as part of a clinical trial, I think it's actually those kinds of treatments are really an exciting idea.
Sure.
And especially in places where they have some experience with it. So I think for people with what we call borderline or locally advanced cancers that can't be removed, those are good strategies to think about and to try to find a clinical trial that looks at that treatment. Can I add one thing to that, Laura?
Yeah,
Do you mind?
Of course.
So I think one of the really important elements of treatment for pancreas cancer, and if I can stress one thing to people with pancreas cancer at all stages, is along these lines, and this question really prompted it.
Okay.
Clinical trials are really critical for patients. That we know patients do better on clinical trials, in those clinical trials, than when those drugs are ultimately brought to market and people get them outside of a clinical trial. There's something about being on a clinical trial where people have better outcomes. I strongly encourage patients to think about clinical trials. Remember that in the modern United States, we're not allowed to take people where there is a proven first-line therapy and give them a placebo drug. We have to give them that drug, but a clinical trial can add something else onto it that may be helpful. So patients, I think, sometimes have this idea in a clinical trial that I don't want to get randomized to the arm. I don't want to get put on an arm where I get a treatment that's not helpful.
Right.
Well, yeah, I get that. I think that's really thoughtful. Most of the trials we do for people who have, potentially curable cancers or potentially treatable cancers, we're not denying them a treatment that we think will work. We can't do that.
Right.
That's just not the way clinical trials work anymore.
Sure.
So really encourage people who are out there to ask your doctors about clinical trials. I think it's an important thing. Not just because it advances the science and will help us solve this problem, but because it really
can help you.
It can be best care for you.
Absolutely.
So I really encourage people to do that.
Yeah,
think about that. And sometimes there isn't a clinical trial available to you, and that's okay too. But it would be important if it was to take advantage of it.
Thank you for bringing that up, because I know it is an important program here and elsewhere to do clinical
and elsewhere
trials.
too. That's not really just about us. I mean, it really is a very important thing wherever people are that are watching this.
Yeah.
And please think about that.
Okay, great.
Because it's oftentimes the best treatment you can get.
Okay. So we just have a couple minutes left. I think this one is just flying by. We have so many questions. We did have a question from Crystal, and I would like to add age group to this question, actually, because she asked, are there certain racial or ethnic groups who are at higher risk for pancreatic cancer? And I wonder about, is there a certain age group?
Certainly, as we understand the age question much better than we understand the racial and ethnic question. And I think, speaking in the broadest terms, pancreas cancer really is a challenge for all racial and ethnic groups. There's no one who's spared. There's no one who's particularly at risk. And I think, although there may be slight differences in one versus another, this is a cancer that touches all of us. Okay. Age is better understood. Certainly, as we get older, our risk of developing pancreas cancer increases. And as our population gets older, in general, our risk of developing pancreas cancer increases. That's very common with cancer in general.
Okay, that goes back to what you said earlier when we started, that it was actually on the increase.
Correct, because our population in the United States is just getting older.
Sure, yeah.
And so I think that's really the group that we think about, that as we get a little bit older. So although younger people can get pancreas cancer, it's less common. It becomes much more common as we get into our 60s and 70s than when we're younger.
Okay. Good to know.
Yes.
Well, thank you so much for being here with us today.
It's been my pleasure.
It's been a very interesting talk, and we have still more questions coming in, so we'll get to those, and we will post the answers online from Dr. Mansour, so we'll be sure to get answers to everybody who participated today. And remember, November is Pancreatic Cancer Awareness Month. Thank you for joining us.
Thank you.